Good evening, everybody, and welcome to part 2 of emergency call handling around the world. We're slightly diminished in numbers, which I assume means people are disappearing off to do things before this evening's fun and games. But unfortunately, if you were hoping to see Kate Jennings' presentation about New Zealand work, and specifically Wellington, she's unable to join us today, which does mean, though, that we'll have a little bit more time to enjoy the 2 presentations that we do have. So without further ado, I'm going to introduce Shakira Cassim as the General Manager of the Contact Centre of ER24 in South Africa. The floor is yours.
Begin to show. Begin to show.
Good afternoon, everyone. I live there, but I'm amazed every time I see it. I must tell you, it's an extraordinary place. I'm Shakira Cassim, and I'm really glad that you managed to make it out to join us this afternoon. And just a little bit about myself. I'm a General Manager for Contact Center Services. Just to provide some context, I work for a private emergency medical services company in South Africa, and actually manage an array of different contact center services. So one of it primarily is you'll notice the number 084124 that comes up on some of our slides. That's our legacy ambulance environment, and we've got a contact center that handles road and aeromedical transfers. And then, the services range from medical information trauma support. We do topside support, which is clinician to clinician support from oil rigs all over the world to clinicians in South Africa. And then amongst that busy schedule, we've got Tier 1 contact center ICT services, as well as 112, which is today's topic. So without further ado, I just thought I'd give everybody a bit of a background through some of our content we're going to cover today. I wanted to take everybody through just a bit of South Africa, just for those who might not know too much about our beautiful country. Talk a little bit about the landscape of the healthcare, because that's going to actually frame some of the discussion points of how emergency medical services works in our country, and then ultimately how the contact center has to adapt to support that landscape. And then we'll go a little bit into some of the contact center specifics, so just briefly around what those calls look like, how they are channeled, what some of those access points look like, and then we'll swiftly move into talking about complexities that we have to handle, the critical success factors that we have to make sure that we can overcome those complexities, and then briefly going to some of the digital solutions that we have, and then concluding on just where we are and where we're moving to. So, South Africa, southernmost country on the African continent. And we have a mixed economy, and we're celebrating this year 29 years of democracy, which is actually quite amazing. A little bit of history and sort of geography sort of lesson today. I mean, we come from the apartheid regime, so 29 years of democracy is really a big thing for us. And it draws, we basically draw on we've got fertile lands, we've got mineral resources, we're quite a good country from a tourist attraction perspective. And more importantly, there's a lot of highly evolved intellectual capital that has come out of the region. So we're known for our mountainous regions, warm oceans, extensive fauna and flora, and of course, we are a 3-time rugby winning nation. And we're hoping to make that a 4th this year in September in France. So yeah, keep an eye out for the Springboks this year. Yeah, that's it. So, I mean, we saw it in the video. I think it's probably high up on one of our prized possessions, and that's the Big 5. So we're home to the lion, the buffalo, elephant, rhino, and leopard. And that's really probably what bolsters our tourism the most. It's all those adrenaline junkies that are keen on safari experiences. Often we obviously find an influx of tourists throughout the year because we also have a climate that facilitates that. So actually, that's something that sets us aside. And if we didn't want to complicate things, with our rich history, we did. We have 11 official languages. And we're best known as the Rainbow Nation because it ultimately describes the diverse cultures, religions, and races that we have in our country. We embrace the Ubuntu philosophy, and it really means humanity. And that really, it translates into I am because we are. And it's going to come through when we talk about what we face. And of course, lots of people keep an eye on media. I mean, there's lots of it about what happens in the region or what happens in the country. And that philosophy actually helps us as a nation to overcome some of the things and the barriers that we face. So, talking about the healthcare system and the landscape, I think it's really important to frame the narrative. So we do not have a system of universal healthcare like it's found mostly throughout Europe. We have 2 parallel systems. We've got a public healthcare system and a private healthcare system, and they operate in tandem with one another. What's quite interesting is that up to 80%, if not more now, given some of the state of the economy, 80% of that population is reliant on the public healthcare system. We do face a high burden of communicable and non-communicable diseases, and these are, it extends anything from HIV/AIDS to tuberculosis, diabetes, and vascular disease. And I'm mentioning it because I think these are key things that we need to keep in mind that and these type of disease, the burden of disease, for example, places really significant burden on healthcare systems and then on our emergency services. So again, framing just the level of capacity, efficiency, and effectiveness that we need to have all the way down into contact centers to be able to deal with that. The healthcare and emergency services landscape as a whole in South Africa is complex and diverse. And we have a mix of public and private services with varying levels of access and to healthcare and emergency services across the population. Social factors such as poverty, inequality, and violence, unfortunately, have a significant impact on health outcomes in South Africa. Addressing these underlying social determinants of health is important for improving the overall healthcare and emergency services landscape. So to talk about emergency services within the larger EMS macrocosm, in South Africa, private organizations play an important role in the country's overall EMS landscape. So, ordinarily when you think private, you're thinking just commercial, there's just sort of net gain, but actually it's probably become the pillar stone and the backbone of our healthcare across the board, across the spectrum. So we work alongside public services to provide emergency medical care and transportation to patients. ER24 is one of the largest in Africa and the largest in private EMS organizations in South Africa. And as mentioned, we work in partnership with public EMS providers. And generally, we sort of bridge the gap where there's not enough, where public services don't have enough resources to provide adequate coverage. And we also serve as a critical backup and support to public EMS services during times of high demand and emergency. So you can just imagine what that collaboration looked like, specifically over the COVID period. Assistance from private EMS extends beyond clinical services, as most public services have limitations and require other assistance. So, I spoke about the landscape, but with that means that there's a lot of responsibility. We've got national parks, you've got endangered species, you've got, so over and above what patients need, there's this bigger environment that needs support. And there's been a lot of sort of investment by the private environment into to be able to make sure that we have the necessary infrastructure, such as bespoke contact centers, fleets of emergency services vehicles, technology, as well as clinical personnel, to enable us to be able to service predominantly privately insured members. But that sort of balance is kind of moving out because public actually needs so much more support. Assistance from private medical services can go from training, rescue services, and standby law enforcement support where necessary. We play an active role in supporting our wildlife parks to handle and deal with other critical needs such as animal poaching, and this includes training park security on how to keep themselves and the animals safe, as well as its first aid efforts where injuries occur. I mean, I think it's no secret, I'm sure most know, rhino poaching in particular is a major threat to South Africa and the world. And without some of these interventions, the rate of extinction would be amplified. So we literally have some of our medics, I mean, during the course of the year, we have scheduled training. We call it MC training. We go out into the parks. We help rangers understand how to use. I mean, that's also backed by resources that have extensive background and knowledge working both internationally and within South Africa in sort of army and tactical response. And we go out there and actually support, have these documented and formal training sessions that actually support these type of rangers to understand how to protect themselves, protect the animals, and protect the park, because it's a real threat. So, private EMS operates under strict regulatory guidelines set by the Department of Health and other relevant bodies to ensure that the required standards of care and safety are met. These regulations cover areas such as staffing, training, equipment standards, and response times. Overall, private companies in South Africa are playing a critical role in providing emergency medical care and transportation to patients, and work alongside the services in the public to ensure that all individuals have access to quality care during emergencies. And I mean, despite me sort of explaining that sort of landscape where we've got private, we know it's for commercial. I mean, of course, there's money that needs to be made through various commercial contracts and agreements with other companies. The idea is that when there's a patient safety issue, or that either as at individual level that our other public services have, or as we saw with the pandemic, I mean, those services come free of charge. And the idea is that we're there to support, to make sure that all our citizens are covered adequately. So let's talk a little bit about the contact center and just touch on access and delivery. I mean, we've heard throughout the week already, and I mean, of course, through all the collateral and all the webinars that we've learned with EENA, that, you know, while 112 is available in most, if not in most European countries, and is generally a single point of access, in South Africa, 112 is only available via mobile network, and coverage may vary in some areas. So that also then puts a lot of pressure on getting access to services. Over and above that, 112 is only one of the central numbers that you can access. So legacy numbers that exist that date far back to the original regime in South Africa for police and ambulance, as an example, still exist, and people can still utilize those numbers to access emergencies directly, especially where those in public don't know about using 112, or possibly someone out there in very, very rural areas that don't have access to mobile technology. So, and the idea is that you can actually, a caller can request assistance from emergency medical services, police, fire, traffic, and National Sea and Rescue, which I'm not sure is available, and obviously not available in all environments. So that's also something that's quite particular. And a member of the public can access services through those numbers directly, and it can differ. So now this is where the complexity comes in. It can differ between those that have the means to be insured versus uninsured. So it's almost that 80% versus the 20% that I kind of talked about a little earlier. And that means that and what actually happens is that there's roughly, and wait for it, 4,500 public access numbers that anyone could call, specific to regions and specific to, we call them provinces, which is a cluster of cities, and specific to municipalities, which have a couple of cities available. So fire, for example, is at municipal level. There's no one single national number unless someone accesses or asks for services via 112. You need to know the police, the fire station within your area, within your town, if one exists. And most of those 4,500 numbers actually belong to the police. So we have a national number, 10111, which can access the police. However, a large number of police stations are actually satellite police stations that sit in very, very remote areas. So generally, you might have and actually, because those 10111 services are also so burdened with reduced staffing and underfunding, in actual fact, most of the time, it's your best bet to actually try and get to the police station directly or try and contact them directly. So private insurance, and this is what I was talking about in terms of the complexity, is that you've got now, with a public service that is so burdened and difficult to get hold of, and where you're not really, they're not really mandated by response times. You have private companies and insurances or environments that actually either commercialize products that public can purchase to be able to access emergency services, and or companies that actually purchase those services via other sort of environments like ER24, for example, to offer those services to their employees and their families. So now there comes in more numbers. So that's over and above those 4,500 numbers that I mentioned, because each insurance or company or corporate that actually implements that generally wants to customize those numbers based on their company name or the service that they offer, or just have a bespoke number that's available for that membership that they sell those to. So that also then can sort of makes that access point a lot broader and can make it quite difficult for people to access. Unfortunately, the demand has grown also for those type of private services due to the lack of availability of the under-resourced public services. By legislation, however, access to 112 services are the responsibility of the mobile telecommunications providers, and they are expected to zero rate those costs. These services are outsourced to private, so just to mention telecommunications providers in South Africa, for example, a big example and a big one for us is Vodacom, which is a division of Vodafone, as known throughout Europe. And those services are outsourced to organizations such as ER24, who are then responsible for setting up and running those entire emergency centers for them, at a cost, of course. There are multiple providers that deliver 112 services as well. So there's no sort of rule that says all the telcos have to use one specific company. Generally, they would go out and tender for something like that, and then different companies have been awarded for that. ER24 has 3 of the 5, the big 5 that we have in the country at the moment. So we are the largest 112 service provider that exists. Right. Now, let's talk about call flows. I don't think we're going to talk about too much that's different from what most of the environments presented this week, but it's really a simple one. An emergency call taker is presented a call through auto answer. That they quickly identify what is required, so the nature of the primary emergency. They assess the public emergency service required if it's not really upfront. So if the person doesn't necessarily say, listen, I need police, they would just quickly ask very prompt questions, identify what service they need, and they would complete a warm transfer with basic contact details to the relevant emergency service provider. So again, third-party sort of transfers, it's warm, it's just saying, right, it's Shakira calling, there's a number, and she needs the police, and that's the end of the call. So on average, the handling time for those calls are 45 seconds, and there is no expectation at the moment for the 112 contact center to follow up on the dispatch of the call. So that's how it operates in the 112 call center. Over peak periods, the 112 daily call volumes can double, of course, naturally linked to times like Easter and Christmas, where, the silly season when everything just goes belly up. And combined, the 112 call centers handle approximately 2.5 to 3 million calls a month. And that's excluding calls that are placed to all the other numbers that I mentioned. So remember, people can call police directly, they can call ambulance directly, and then within the different provinces, regions, like I mentioned, those are clusters of cities. They also then have their sort of provincial numbers that people can access. Aligned with some of the discussions that I've heard over the last 2 days, approximately 40% of those are unservice calls. And really what that means is that calls placed to the 112 numbers are not necessarily emergency related. And these also include hoax and prank calls. These volumes of the hoax and prank, ironically, are linked to, we didn't hear about how, if there's any trends that were noticed around that. What we've picked up is it's seasonal, or in terms of some certain behavior. So school holidays, we see that almost double, of course, because of kids and them using the services irresponsibly. Medical and police services are the highest volume of service calls. And to talk a little bit about location services, that is pretty, it's in its infancy stage. We're not without some form of services. Vodacom and through Vodafone, for example, which is a large telco in South Africa, provides us with GMLC. So that's actually quite accurate. We get good quality of location services for their 112 calls. Through some of the private contact centers where we handle emergency calls, our systems can handle anything from 3 words to using, we've got integrations with Google Maps. So if you get the location either via coordinates or a physical location, you could type that in and that could give you guidance in terms of where the location is. But there is a lot of work that's being done at the moment around trying to bridge that gap. And there's been discussions around ELS and AML and all of those type of things. And I think the idea, though, is that in order for that to happen, we need to have sort of cohesion and collaboration across all the environments to be able to do that. It's quite difficult to do it as an individual environment, but hope's not lost. I'm sure we're going to be able to see some of that change shortly. Complexities. No, I'm kidding. I was going to say I had to try and keep that at a minimum, but I tried to sort of put them under, or cluster them, according to some of the concerns and issues that we explained. Handling emergency services calls in our country can be complex, and there's a various range of factors that impact the overall EMS landscape in the country. Resource constraints is one of them, and as it exists as a result of staff shortages. We heard it earlier during the course of yesterday. A lot of that, though, focused purely around the call centers themselves. Now, the resource constraints that we find that impacts us the most is the clinician shortages that we have. So, the contact centers leverage of technology. If you've got the right technology and the right training plans, we can bring in the right people into contact center. However, it does make it difficult when you have limited resources to be able to send out to calls that you receive, whether it's from emergency services, so ambulance, police, fire. We under-resourced quite a lot across all those environments. So those we've got staff shortages, there's equipment shortages, and medication sometimes can be quite a bit of a concern. And these have a direct impact on the ability of the call centers, like I said, to be able to respond, to find the resources to respond efficiently and effectively. Interesting, that we talked about, we're hearing about the shortage of resources around the European environment, because one of the biggest reasons why we have a shortage is because of the exodus of our staff to specifically European and Middle Eastern countries. I was actually in the Middle East at the end of last year, and they then further complained that the staff they took from us have now moved on to the UK. So it's just this vicious circle, who can offer the best. And as we know, those are linked to more favorable remuneration and benefits. So we're a large country, diverse geography, tried to cram that view as much as I could into the video. We've got everything from the ocean to the wild, to the parks, to rural, to urban. So that then brings in quite a bit of sort of complexity in handling the calls. And there's limited access to healthcare facilities and transportation infrastructure. So this makes it challenging to find EMS services in some areas. So that means that some response times could take hours. Some environments in South Africa don't have street names. I mean, they're quite informal. And there's a heavy reliance on location-specific landmarks, such as unapproved and undocumented shops and churches. I mean, like someone would say to you, listen, it's a church in the corner of the street that's next to a red house, and it's a tent. So, I mean, that's really what that, I mean, I just think, just trying to explain and just understand what some of the call takers have to deal with when taking an emergency call. Poor oversight within parts of the country is believed to have led to insufficient and failing infrastructure. And we currently have daily load shedding. For those who are not familiar with what that is, it's the limiting of electricity. So that also then poses a lot of concerns. Of course, our contact centers are, in particular, the private environments like ours have got full generator capacity and are putting in solar and all of that to be, and we are 24 hours in operation, irrespective of these limitations. But I mean, the public services already, with limited funds, are starting to buckle under that pressure. We've got damaged roads, poor healthcare facilities in some areas, and these are just some of the daily challenges that our EMS environment is faced with. And this leads to extended response times and could result in poor outcomes. During natural disasters, which fortunately we don't have too many of, I mean, it's just like touch wood. I mean, we haven't been shaken with anything major like earthquakes and things like we've seen with Turkey recently, for example. But if that was the case, we would be under some threat, given what the infrastructure looks like. Social economic issues exist due to high unemployment rate. I mean, I should have started with this in my South African slide. We're sitting with close to 60 million, a population of about 60 million. So we're I don't think we're a country to scoff at in terms of size. But then we also sit with an unemployment rate that's peaked close to 50%. So that's quite high. And we face social threats on a daily basis because then there's poor access to transport systems. And then that sometimes means that members of public request emergency assistance for non-life-threatening situations, because it's like a bailout. That's like one of the only options. And this draws on the burden system already, and it leads to the inappropriate use of EMS. So it's actually like a sort of vicious circle, and this means that there might not be the appropriate level of care available when a true emergency comes through. I mentioned we have 11 official languages. It is one of our key points of diversity, but then that also brings challenges into the contact center. We're very fortunate to have, for example, at ER24, we have a broad range of that, and we cover all official languages. Fortunately, if you are Zulu speaking, for example, you can speak 3 of those 11 already. English is broadly spoken throughout South Africa, and in fact, all our schools are now English-based. But still, that can be difficult when you've got someone in an emergency situation and you need to, if you don't have this endless supply of people with that language, and if you've got to try and source that information from the informal settlements where people do have poor command of English, it can be a bit challenging. We also have, limited public awareness of emergency medical services and how to access them during emergencies, and this can lead to delay in seeking care. But you'll see when we talk about some of the things that we're working on and the critical success factors, there's a lot now being done. And the advent of social media and those type of things also helps us to be able to get that message across more broadly, so that people can become more responsible in using it. And lastly, then, that limited capacity to grow the EMS talent pool. Our education sort of sector is under strain. there's a bigger demand than there is a supply. And then, of course, because of that, you aren't able to sort of put through those people who are showing that intent long enough. So good. Then we talk about quickly the critical success factors. We've got research committees. We've got computer-aided dispatch systems that are continuously evolving. I'm hoping that by the time we come back next year, we're able to show you some of the key development stuff that we're busy with. We talked about the public-private partnerships that that are quite interrelated and that work together to make sure that we get things done together and that we can work quite closely. Public awareness I mentioned, and just a special mention on the research committees. I mean, our universities work quite closely with us, data mining and then doing some research projects. One of the good ones that we had recently was the research aimed to understand if callers within our provinces of South Africa actually can do that.
Sorry, we are running very much over time.
Okay, cool.
We've got a couple of headline points we want to throw in and ask you to wrap
Yes, yeah, we're wrapping up. Okay, so voice remains the core access. I think that's something that we spoke about during, I think we heard throughout the conference. I mean, we heard yesterday one of the winners in terms of the mobile app for special needs and for hearing and speech impaired that was launched in 2019 here in Europe. We launched it in 2018. So we're quite proud of that. It was the first in Africa and clearly quite early in the world as well. And then just in terms of talking about all the different digital stuff, we've got relay services, we've got wearables and panic alerts, and then digital clinics that have evolved. So that's also helping us bridge some of those and reduce the access to actual emergency services. And then talking about ongoing and current initiatives, I think we highlighted that if we got better government funding, there could be a better access from a public perspective and less strain on the rest of the environment. Training, retraining, and then infrastructure development, and of course, integrations that are quite key that we hope to show the environment, the conference next year between the PSAPs and the private emergency services environment. And yeah, that's it. That's a wrap.
Thank you very much. I'm going to ask you if you could hold any questions to the end, because I'm sure there will be quite a few from there. I've got a few myself. I'm sure we could have probably listened to that for another hour. It's quite fascinating, but we don't have another hour. So I'm going to take the opportunity to introduce Roger Cornelis, who's the project manager for NTU 112, or the Federal Ministry for Home Affairs in Belgium. Roger, the floor is yours. Thank you.
Thank you. Good afternoon. I will try a little bit to speed up so that you can all get to the social event. This is the situation that we had until beginning of last year. And we were planning on coupling these closer together. And then we had the Brussels bombings, and that has speed up some things. And this is where we are going to. We still have 10 PSAPs for fire and medical services, but they all share the same database today. This is the call model that we follow in Belgium. This morning I had a speech about the IVR, so I'm not going to repeat that. We in the Ministry of Home Affairs, we are responsible for this part. And for communication purposes, there is, of course, a phone link between those two. There are 3 provinces where we also have a data link, but that data link is limited to that province only. Then here, there's usually not a phone conversation, but only a data link. Same here. But this data link is very simple, and we are moving it to the open standard, the Common Alerting Protocol, where we have, specified which fields are going to be used for what. I would like to add one thing to that Common Alerting Protocol. There is an acknowledgement message that is sent on receipt of an alert message in this direction. The acknowledgement message comes back. We have defined 2 levels of acknowledgement. The first is an automatic one, where the computer says, I have got your message, I have understood the format, and I have stored it safely to disk. The second acknowledgement is a transfer of responsibility, where someone, it can also be automatic, but the responsibility is taken and services are really being sent out. Now, we also do non-urgent fire services and medical services. And of course, in that case, we are not interested in that second level acknowledgement. That is only important for the emergency services. This is the Belgian situation. These are our provinces. We have a PSAP in almost every province. And to make matters more complex, we have 4 language regions. We're only 30,000 square kilometers, 11.6 million people. We have Dutch-speaking people in the north, French in the south, German in the east, and the big red dot there is Brussels, which is bilingual, French and Dutch. And when we went from one PSAP, well, for non-interconnected PSAPs to one single PSAP, we had some requirements, and they are listed here. Preferably, we treat the call still in the provincial PSAP. There are, well, 2 major reasons. That's the language, of course, and local circumstances. Another requirement is that every PSAP must be able to dispatch means all over the country. So if you are on holiday on the Belgian coast and you're calling for your mother who's in distress somewhere else, then they can dispatch the ambulance at the other side of the country. Once the alert goes out, the follow-up is handled by the province where the incident is. And to do that correctly, and also at the other end, not overwhelm the operators with information, the calls are only visible if one of these conditions are met. So either you have handled the call, or one of the calls, the intervention is in your province, or one of your ambulances is going to the intervention. When we went to a national system, we have also taken precautions so that there's still some boundaries left, and you can see them here listed. One of the concerns was also that if we made everything visible, we don't want everyone to check on everyone. So therefore, we have some limitations built in, of course. The when involved that you see in the almost left column is has to do with the previous slide. So here on the dams, if you are in one of those 3 cases, then you are involved with the incident. For telephony, we had an old system where there was the operators were picking out the phone calls as they felt they were important or not. We don't want operators to wait for calls for their province. If they get a call for another province, they have to answer it. So the calls are now pushed. The calls preferably go to the right province, but if not, they go to the right language region. And we have overflow defined for all public call groups. These are the 3 numbers that we use. And for one non-public call group, which is priority-based because they are already filtered. Those are accredited alarm control centers. This is the simplified version of the call treating. So we have a check, is there someone free? If not, the call is queued. Then after some time, it goes to the language operator, and there we have the same mechanism, of course. We didn't want, when we changed the system from cherry picking to call pushing, we didn't want the operator to feel completely uncomfortable. So we tried to keep a similar priority system. And this is actually what the operators can choose. So they can say whether they are in the first line or whether they prefer to have a calmer moment. They can say, I'm taking 112 or I am taking 112 priority, which is the accredited filtered alarm control centers with the filtered calls, or the fire services themselves, or the police that calls us, or non-priority calls here. And then for the coordination, we have the team leader, CS0, and we have 3 reserved numbers for special events. The numbers can be distributed when something happens, or you can distribute them up front, depending how you organize, how each province organizes itself. I think I'm going to skip this. Those who are interested can look at the skill levels and how the calls are treated. I have the calls come in here. I have left out the columns for the non-priority, for the non-urgent calls, and this is what the operators can indicate. And then this is how the priority works when multiple calls are queued. When we did this, actually, we were faced with 10 provinces where often ambulances of nearby provinces had a different name, stuff like that, where they called, well, a hospital, for instance, the name started with hospital, and other provinces, the name ended with hospital, and things like that. So actually, we have reloaded the complete database. We found phone numbers of doctors that had already died for 10 years. And we loaded the database from official lists. Of course, important thing, naming convention. So you can, at a glance, you can see this is a hospital, this is an ambulance, this is a medical urgency group, fire service, whatever. You can see there is one letter that indicates which province is involved, and then you have abbreviations where we have for every town in Belgium defined a 4-letter abbreviation, so that you can quickly see where it is located. Advantages, you have no discussions about names anymore, because it's sometimes incredible. And it's because we load it from official lists, it's relatively easily updatable. In the database, we keep the list we loaded from and the index in that list so that we can update it or delete entries or whatever. Visible medical teams located in the own province or near the own province or active in the own province. So it's possible that you don't see a certain ambulance and suddenly it appears on your screen because it's been used for some for being sent to an intervention in your province. Dispatching rules must be usable by all PSAPs. There's versioning built in. We can tie it to a specific area. We try to avoid that. We do use it for example, a NATO base where you can't send an ambulance in or even a fire service in without being accompanied. And then we have a list of possible pitfalls. You have to set the expectations right because the system is completely different. You switch from cherry picking to call pushing. You have, of course, a different map, but that's almost business as usual. You regularly have a different map. Did I mention naming convention yet? We had in almost all provinces exceptions, favors to the local fire service, to the local medical post for the non-urgent medical calls. And then something that's quite sensitive, quite sensible, on overflow, you have to know that 1 FTE is not equal to 1 FTE. If you have a PSAP with 3 people and you have a PSAP with 10 people, the one with 3 people is going to receive more overflows than the other one with 10 people. And what we also found out is that you have to plan a circuit breaker in case of large network outages, because your teams could otherwise be called by other provinces, and then you don't have a view anymore of what is going on in with your own medical teams. Advantages: you have a more evenly spread workload. And then the second migration, we immediately had an example why we did it. The second migration was coupled to a physical move. It was a physical move to a new building. And UPSs and whatever were in place. Unfortunately, the wiring was not okay. And we found out the hard way, because we had a electricity outage the first evening, and the first province could already help. So that was a nice add-on. It makes it also very easy if you need to evacuate the center. That's about the same principle. And then other examples, during a storm, usually the storm moves over the country. So if you have one province that gets overloaded in the beginning of the storm, other provinces can assist. And since the storm shifts over the country, that helping between provinces shifts as well. Well, empty sites, that has to do with the possible evacuation of a site. You have seen in the call flow that there was a timeout. If there's no one connected, the timeout is automatically brought to 0. Then the calls are immediately queued to the language skills instead of to the provincial skills. And yeah, that's the last point, is something still for the future. It's planned, but it's not, the procedures are not in place yet. The migration takes up a lot of time and effort, so this is for later. We can see which operators are logged on the whole country and what language that they know. So with this, I'm terminating my presentation. And do we have time for questions?
Yes, thank you very much again for a wonderful presentation. Yeah, we do have time for questions. If people do have any questions. One at the back. I'll see you against the light now. If there's none from the audience, there is one from me, I'm afraid. You don't get away that lightly. How do you identify the language of the caller? Is it someone has to answer it and pass it on, or?
Yes, it's not an IVR. It's not a question of the IVR. It's when the call is not yet. When the call is passed on to a real operator, then they know the language, and then they may transfer the call to the right colleague.
Any other questions at all for either of our presenters this evening? Yes, sir.
A little bit of local knowledge on the South African side. So, Shakira, could you mind just explaining how the large portion of South African industry is unaddressed? So, solving that for location. A two-part question. The second is, it wasn't very obvious, but just make clear for the room how hard the challenges that Shakira is facing is. It's not a government-mandated call center that is taking the 112 call flow. It's just the mobile network. Is that correct? Did I get that correct?
Correct, yeah. So, Stephen, I didn't get the first part.
The first part, just about, I'm working in America, we're talking about problems in Europe, but I think 60% of South African addresses are informal settlements. So you don't have street addresses, you don't have centre lines, you don't have all these kind of things. So they're trying to navigate an ambulance to a call site, very, very difficult kind of workflow than anything we would expect, in first world.
Yeah, spot on. Steve. I mean, that's really one of the biggest issues. I think we touched a bit on the whole issue between urban versus rural,
Yeah.
and mentioning that some of the, when we talk rural, it's not just sort of proper housing in a rural environment. It's a rural environment, but also with what we call informal settlements. So addresses and all that. We've tried a lot of different types of technologies. So we have satellites, companies that have gone in and put satellites, for example, so that you could use it as a marker to navigate to certain areas, etc. So there's what 3 words as well that we've gotten that's coming, but a lot of work still to be done around getting the infrastructure settled and then also getting more technology users to support us.